Hi, I'm Brian Rini from Vanderbilt-Ingram Cancer Center. I'm here at the GU Oncology Now ASCO roundtable with my friends and colleagues, and I'm going to let them introduce themselves. We're going to talk about frontline kidney cancer and then also talk about refractory kidney cancer incorporating the latest data. Tian?
Hi, everyone. I'm Tian Zhang, an associate professor at UT Southwestern Medical Center. I'm really glad to be here today.
I'm Pedro Barata. I'm also a GU oncologist at University Hospital Sideman Cancer Center, Case Western in Cleveland, Ohio. Also very happy to be here.
And I'm Michael Atkins, a medical oncologist and deputy director of the Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C., and I'm delighted to be here.
Thank you all for coming. We're going to talk about kidney cancer. We're going to incorporate some ASCO data. There's several phase 3 trials that have either been updated or new data. And again, talk about the frontline and refractory space. I think there's been a lot of exciting data and some potential practice-changing data. So Tian, I'm going to call on you first. Let's talk about, as you were heading into this year's ASCO, tell me about your algorithm for treating patients.
Sure. So we know there's multiple approved immunotherapy options in the frontline space. So I start there, right? So there's ipilimumab, nivolumab for a pure immunotherapy approach. We know CTLA-4 inhibition has a great role up front. So for patients who are immunotherapy appropriate and looking for durable responses, I'm starting there. For early disease control and early responses, I turn toward the VEGF-IO combinations. So we have multiple now approved, axitinib with pembrolizumab, axitinib with avelumab, which is not often used, and also lenvatinib with pembrolizumab, and then finally cabozantinib with nivolumab. So as we go down those treatment algorithms, and I'm sure we'll talk through all of those data, I'm often thinking about patient characteristics and then how quickly they need a response.
So are you, just to clarify, sort of ipi-nivo as a default, assuming they can tolerate ipi, et cetera, and then if they have bulky symptomatic disease, you might lean towards an IO-TKI? Is that a fair
That's a fair
summary?
assessment,
Okay.
yeah.
And when you give IO-TKI, what do you give?
I actually use all of them. So if I'm thinking I want to save cabozantinib for the second line or later, I'll start with axitinib with pembro or lenvatinib with pembro. If I'm looking for really good early disease control, I might lean a little bit more toward cabozantinib and nivolumab or toward lenvatinib with pembrolizumab.
Okay. So yeah, higher response rates with len-pembro, but more toxicity, which we'll talk to. Okay, Pedro.
Yeah, no, great summary, Tian. It was perfect. I guess as you're walking through your way of approaching those patients, I would probably highlight, I'm assuming your answer is referring clear cell, right? So for non-clear cell, we also have data supporting IO-TKI in that setting with lenv-pem and cabo-nivo. So for that reasons, I do care about that, and I do offer an IO-TKI in general to patients with non-clear cell. And then other factors, we do start having data about specific subgroups, patients with bone mets, patients with liver mets, maybe CNS disease, although we also address them locally first. And for those patients, I tend to use a bit more IO-TKI. And then my final point was obviously one of the things we care is sarcomatoid rhabdoid features as well, which I definitely take into consideration that and also trying to favor definitely IO, if not IO, meaning, I do a lot of ipi-nivo in those patients as well.
So ipi-nivo for sarcomatoid, right? And there's some good, albeit subset, retrospective data. And then were you saying that you choose based on site of metastasis?
Well, no. So because all the patients are different, right? I think presentation of location of mets matter in the way I think about it. Not necessarily symptomatic patients or visceral crisis, but I do think of a patient who has, a number of liver mets in addition to lung, lymph node, very different way that I look at a patient with a pancreatic met or a few lung mets. So if I have this urgency and I really care about how likely is the treatment, whatever I do, not to work, and do what data do I have to do in those cases? If I really concerned about this might be my only chance, and we tend to think that liver mets and bone mets are almost like behave differently, I tend to go an IO-TKI that provides with that. In general, I tend to think of cabo-nivo, lenv-pem in those cases, but
okay.
Yeah.
So what you're referring to is that PD has best response, which is about 5 or 10% with the IO-TKIs and more towards 20% with ipi-nivo. And that may have consequences, not in all patients, of course, right? Small volume disease, not, but okay. Mm-hmm. Mike?
Yeah, so I'm not dissimilar from what both of you have presented, although maybe a little bit more biased towards giving IO to most of the patients, because I think most of my patients want a durable response and want to be able to stop treatment and get back to their prior lives. And pure IO regimens are the only ones so far that we can see that can actually do that. And I think the data presented at ASCO suggests that that may still be the case. I think I take patients who have really aggressive disease and where we absolutely need a response, patients who are really symptomatic or in the hospital. And if they have heavy bone metastases, I might give them cabo-nivo. If they have bad lung disease or something like that, I might give them len-pem. But for the most part, I view TKIs, which are great drugs, but as drugs that are not curative, and I try to delay starting those as long as possible in my patients.
Two questions for you. So what % of patients in your practice will get an IO TKI based on those parameters?
Probably 5 to 10%.
So fairly low percent. And then what % of patients walk into your clinic and you think, boy, this patient's just not going to tolerate IPI. This is going to be too much for this patient. Put aside rheumatoid arthritis or, autoimmune or organ transplant or something like that, but just sort of their performance status and fitness level makes you worry.
Yeah, well, I think if they can't tolerate IPI because they're old or, you're worried about their performance status, I think it's going to be hard for them to tolerate IO TKIs as well. And so I would rather either do a IO or ipi-nivo with a very short leash, or give single-agent anti-PD-1, which we know has activity. If you have a patient who, let's say, has an autoimmune condition, history of colitis or history of arthritis, where I'd be worried about giving them IPI, I think it's fine to give them single-agent anti-PD-1, and I'd rather do that than an IO TKI in that setting.
Okay, interesting. So I'm probably a little bit different. I tend to be an IO TKI guy. I give ipi-nivo to younger, healthier patients, obviously, that I think can tolerate IPI, and sarcomatoid for sure. I think any degree of sarcomatoid, would buy them ipi-nivo.